Hey, it's Tony again for TRW Medical Training. Hope everybody's doing well. I received a request here to do a little trauma stuff, just for fun. So I found a case here, and I'm just going to go cold turkey with you guys, okay? So here we go. This case introductions begins like this. We got a 21-year-old male with gunshot wound to the neck. Currently breathing independently and able to speak. Heart rate is in the 140s. Blood pressure is in the 100s. Sats are 99%. Pain and swelling to the right side of the neck. Bleeding controlled with pressure. C-collar not in place due to the direct pressure being held. Denies other pain or injury. So the triage nurse charted 21-year-old male with gunshot wound to the neck, breathing spontaneously, no obviously neurologic deficit. Heart rate 135, blood pressure 99/68, directly to the resuscitation bay. Okay. So he's 21 years old. He's got a gunshot to the wound to the neck. He notes he was involved in an altercation with a stranger outside of a bar. The stranger pulled out a gun, and the patient began to run away when he heard several gunshots. He then felt a severe sharp pain in the right side of his neck. The shooter fled the scene, and the patient was able to call 911. He currently reports persistent pain in the site of the wound. He denies vomiting, hematemesis, vocal numbness or weakness, chest pain or abdominal pain. He has seasonal allergies. That's about it, really. He's on fexofenadine, so that's he has for allergies and stuff. You see. He has a social history, occasional alcohol, positive for half a pack of cigarettes daily, and then he denies any other substance, okay? So let's go directly into the exam here very quickly, all right? Let's go into the exam. Here it's going to ask us, do you want, everything that you have available, all your tests and everything here, your diagnostics are going to be here. So this is going to be fun, all right? We're going to do this cold turkey here. Do you want to perform an airway exam? Absolutely. The guy just got shot in the neck, right? So he has audible stridor present. Okay, so that tells me there's upper airway swelling, and he's in danger of some serious upper airway issues. So we might be looking at stabilizing the airway with rapid sequence drugs and intubation. That's the way I'm looking at it. Okay. Perform breathing. He's tachypnic, bilateral, symmetric breath sounds with normal chest rise. Okay. Circulation, let's see, +2 peripheral pulses, normal cap refill, all right? Disability, perform disability exam, I'll say yes. You gain points or lose points depending on what you choose. It's kind of like our 10 clinical simulation scenario thing when we take our registry boards. So here we go. His pupils are equal, reactive, patient can move all extremities and no sensory deficits, all right? You want to perform an exposure exam? Yeah, I guess so, yeah. Patient, no, we'll do that. He's fully undressed. There's no obvious deformities, chest wall, abdomen, pelvis, or extremity or anything. Perform HEENT exam? Yeah. So he's normal cephalic, all right? His oral pharynx is clear. The PERLA, the acronym for the pupils are equal, round, reactive to light combination. That's what that acronym means. And his voice is slightly hoarse. I guess mine would be too if I just got shot in the neck, right? All right, neck. This is what concerns me. So yeah, I clicked on neck. I want to see what's going on with the neck here. So he has swelling to the right side of the neck, no tracheal deviation. Good. That's a big one. Pulsatile mass, or air bubbling, or arterial bleed. Well, that's good. If he's got no, tracheal deviation or air bubbling or subcutaneous emphysema, which would really concern me even more at this point, All right, doesn't sound too bad so far, but still keep in mind he does have a little airway swelling, I believe. Perform cardiovascular. Yeah, tachycardia, regular rhythm, no murmurs, rubs, or gallops. All right. Pulmonary exam. Yep, he had tachypnea. He's cleared auscultation bilaterally. That's good. No retractions, wheezing, rhonchi, or rales. Good. Perform abdominal exam. Yeah, why not? I'm gonna check this kid out here, man. Soft, non-tender, non-distended, normal active bowel sounds, and all that stuff. Okay. Rebound or guarding out of that. Well, genitourinary exam. Let's go ahead and check that out. Because well, let's see what he's got. He gets. Look at here. He's got half a centimeter puncture wound to the central right buttock. How about that? With mild oozing blood. 1 centimeter wound. With rounded irregular edges to the mild lateral buttock with mild oozing, normal anatomy, no masses or hernias, or none of that rectal bleeding. Okay, so back flank, no CVA. All right, that's good. Musculoskeletal, why not? No clubbing or nothing. He's got good range of motion. Check out his skin, You want to see, the skin can tell you a lot. He's diaphoretic, all right? So he has a half a centimeter puncture wound to the right lateral posterior neck, okay? You know that. And it's approximately 5 centimeters lateral to C3. Ooh. C3, how about that? With mild oozing of blood. A 1 centimeter wound with rounded irregular edges to the right anterior neck. 2 centimeter lateral wound to thyroid cartilage. Can you dig that? Perform neurological exam? Yeah, why not? Ooh, look at here. He's minimally responsive. Incomprehensible speech. Withdraws all 4 extremities to noxious stimuli. There we go, my friend. There we go. As an RT with 41 years experience in trauma, I can tell you this guy's going to buy an endotracheal tube. Number 1, he's becoming more lethargic, unresponsive. He has swelling in the neck, right? That area right there. A lot of things can happen, okay? So he's probably going to be losing blood. If he's bleeding underneath there, he's probably going to get, just to put it simple in basic terms, he's going to get some swelling in there, which can cause issues with the trachea. In other words, it can cause a deviated airway, right? Begin to push that anatomy to the side right there, and actually, destroy his airway. So let's move very quickly here. Bedside test and stuff. I'm thinking we're going to intubate this guy. What do you think? What do you think? We're going to be intubating this guy? Okay, let's just do this quickly here, just to be thorough. You want a Doppler? No. You want ACG? Well, okay, by the way, did we go, so we should have our IVs in, right? Attach IV, attach monitor, let's do a chest x-ray, insert a chest tube, ultrasound fast, so oxygen, I'm gonna put him on, a couple liters. Procedures, pelvic binder, A-line, C-collar, central venous catheter, nah. Remove the C-collar, he doesn't have one. Okay, so now my choices here are vascular. I'm gonna get another IV. Always good to get a second IV, especially in a situation like that. If you don't have time, go IO. Just slam an intraosseous in there. Super easy to do, I've done hundreds of them things. They're very good, especially in peds when you're in a pinch. Don't be wasting time. You don't want to do any central line stuff right now, So just you want at least minimum 2 IVs for this guy, right? Now I'm still considering intubation, so let me show you this guy. Check it out. All right, he's shot in the neck. There are your vital signs, your blood pressure. He at the moment. He's not looking back too bad. He looks tachycardic, 141, sats are 94. He's breathing 30 times a minute. He's a little stressed, just understandable. Blood pressure is 104/68. Yeah, it's not that bad, but it could be a lot worse. So let's go ahead and intervene here. So we want a 12 lead. I don't think we have time for that right now. Okay, you can. I'll throw it in there. I'll do a blood sugar because that's not the issue there. Ultra long, nah. Lab work. All right, so I guess we can get a blood gas. Chem 7, blood type and screening. Yeah, let's get a CBC. I guess we get lactate. Probing D, troponin T, urinalysis as well. Yeah, I've seen physicians order all this, and I've seen them not order none of this. But I guess let's look at other labs here. We don't need a TSH or urine tox screen at the moment. I think we have other urgent matters to take care of. Let's go ahead and do an X-ray, okay? And let's perform this stuff here. Okay. Let's see what we got. Well, we got a lactate of 3 millimole. Okay, so the range is anything like 0.4 to 2.3 millimole. So it's a little high. Probably going to be related to perfusion issues. Look at the white count. Yeah, the white count's a little bit high. All right, hematocrit's 27, hemoglobin's 9. All right, for a guy that's 21, it ought to be in the teens, the 14s, and that kind of thing, right? Platelets are good. All right, your basic chem, sodium, potassium, chloride, and all that is okay. BUN, glucose. Okay, the blood gas here is my specialty, of course. The pH is 7.4 with a CO2 of 30. So, you know, the pH is perfect, 7.40. So, you know, he's trying to compensate also for a metabolic issue. He's got, you know, his oxygenation is 99, blood sugar is 69. Let's look at his chest X-ray right here, right? To me, it looks normal. Diaphragms, the trachea is midline. I don't see any evidence of subcutaneous emphysema. I don't see, you know, any increased lung markings, atelectasis, any shift or anything like that, you know. So his lungs at the moment look pretty good to me. Okay, so that's what we're gonna do. All right, so I'm concerned with this kid here. I'll tell you what I think we need to do with this kid. I think we need to stabilize the airway, all right? That's my pitch, man. If I was working in the ER with an ER physician, I would say, hey, I suggest intubation for this 21-year-old that's shot in the neck. And we know why, right? I'm not liking what's going on up here. So if you have any stridor involved and he's swelling and he's getting lethargic, I'm not liking it. So let's go ahead and, you know what we did not pick? A differential diagnosis. Good grief. They're gonna make me do a differential diagnosis. All right, is it cardiovascular, dermatological? Yeah, he's got a pimple in the middle of it. No, I'm just kidding. Endocrine, environmental. Okay, let's see. Come on, give me something here. Let's go with trauma vascular, of course. All right, here are my choices. Abdominal aortic aneurysm, no. Aortic dissection, no. Aortic enteric fistula, no. Cardiac contusion, no. Closed head injury, no. Mild traumatic brain injury, no. How about deep vein thrombosis? No. Epidural hematoma, esophageal rupture, possibly. Flail chest,